Good afternoon, ladies and gentlemen. Welcome to the joint health and overview scrutiny meeting. And this is a virtual meeting. This is our first one, so please bear with us as we work our way through this process. I'm going to ask Joseph Galski to give the process, to give the sort of the housekeeping rules of the meeting and as it will be run so far. Thank you, Joseph.
Hello, everyone. Okay, so please remember that today's meeting is being recorded. Both the video and audio is being broadcasted onto YouTube, and as I said, recorded. Please can members and agenda item presenters mute themselves and also have their camera off to allow the Wi-Fi signal and broadband width to be better to ensure a quality meeting to occur. Members, please use the chat function to indicate you would like to speak and wait to be invited by the chair to speak. If anyone or if any members have any technical difficulties, please contact myself, Joseph Galkowski, Democratic Services and Scrutiny Officer from Telford and Wrekin Council, or Daniel Webb, the Overview and Scrutiny Officer from Shropshire Council, and we shall be able to assist you. And I believe that are all the housekeeping reminders I need to give, so I'll pass it back to the chair, Councillor Karen.
Sorry, I forgot to introduce myself. My name is Councillor Karen Calder and I'm co-chair of this committee. Can we have apologies for absence?
I've had no apologies received.
Okay. Can you please run through the attendance list, and can members say that they're present, obviously, and then declare if they have any pecuniary interests?
Okay, so I will begin with Chair, yourself, Councillor Karen Calder. Do you have
Obviously,
any?
Yes, present, and I have no pecuniary interest.
Okay. Councillor Heather Kidd.
I'm present and I have no pecuniary interest.
Thank you. Councillor Madge Shinton.
I'm present. I have no pecuniary interest, but I do belong to the health concern Kidderminster Hospital.
Co-optee Ian Hume.
Present and no pecuniary interest.
Thank you. Co-optee David Beachy.
Present, no pecuniary interest.
Thank you. Councillor Derek White from Telford and Wrekin Council.
Present with no interest.
Councillor Stephen Reynolds.
Yeah, present, no pecuniary interests.
Co-optee Janet O'Loughlin.
Present, no pecuniary interest.
Co-optee Hilary Knight.
Present, no pecuniary interest.
And Dag Saunders. Co-optee.
Present and no pecuniary interest.
Thank you, everyone. That's all members, Chair.
Thank you very much for that, Joseph. We'll now go on to the next item of the agenda, which is the minutes of the previous meeting. This meeting was held on the 2nd of March, which was a long time ago, and obviously it was just on the cusp of COVID. So we have the minutes before us. Can I take that unless any member indicates otherwise, that this is a true and accurate record, and be able to sign them off? Dag.
Just one issue. I think the first item where it says an increase refers to flu vaccinations. I think just to add that.
Yes, I thank you, Dag. I did pick that up and then forgot to note it down. So yes, can we please amend those minutes to say that it was referring to the uptake of the flu vaccination? It seems to have missed a line out of it, I think.
With that amendment, Chairman, I propose we accept them as a true record.
Thank you. I'd also, I will sign them off. I'd also like to bring to the attention that there are a number of actions that have not been completed in the minutes, and I will, as chair, pick them up and take them up. I think David Evans, quite a few of them refer to some information from you. So if I can pick them up out of the meeting and then ensure that they're circulated, attached to the minutes of this meeting.
And with that addendum, I'll second that.
Thank you. So we now swiftly move on to item 4, which is COVID-19 Restore and Recovery System Priorities. We have Kate Manning, who is presenting this. Kate, are you with us?
I am. Thank you for having me. I'm just going to attempt to share my screen with you. So
Thank you.
Okay.
Sorry, Chair. Before that, I thought the first item was from Steve Trenchard, unless I'm mistaken.
Oh, it is. I'm terribly sorry.
That's fine.
I'm terribly sorry. You're absolutely right.
My apologies for interjecting.
No, thank you for intervening. I read COVID-19 Restore and Response, and I'd written Kate's name down next to it. So apologies to you, Kate, and apologies to Steve. Steve, I know you're with us, and I believe you have a number of other people with you to support. Can you share your screen with us, please?
Certainly, thank you. I thought there was an imposter in there then. Can you see that, Chair and colleagues?
Yes, thank you.
Excellent. Okay, so this item is to talk through JHOS colleagues on what we've been doing post-COVID and the system response and some learning, as well as the proposed way forward, given that since this presentation was written, we've had what's called phase 3 letter from Simon Stevens and Amanda Pritchard around the ask for NHS services, and also there's been a similar letter out to directors of adult services as well to make clear the local authority ask. I guess to start with, when COVID was first alluded to and talked about, we were expecting a very big surge nationally, and what we've experienced, of course, is a high degree of variance in relation to how COVID hit our NHS and care services. So we didn't have the size of surge that we were expecting, and we were able to accommodate with our current capacity the demand arising from COVID. And similarly, COVID didn't go away as quick as it did in some of the major cities. We had a long tail. What we've tried to do is to focus on what we've done well and to keep people safe in that period. The immediate response was to go into a critical planning mode, which is a mode that's required in phase 4, where central coordination through the Department of Health, regional oversight, but a key relationship and partnership between local authority and CCG. So our local health resilience partnership stood up as it did in winter with the floods, and stood up again with a different structure. The immediate response was to mobilise all of the resource around COVID, and I'll talk you through some of that as we go through the slide set. Effectively, when a pandemic hits, there's the first wave, which is what we were expecting, and here your focus is on oxygenated and critical care beds for those that are most unwell. We also had to plan for a second wave, and that planning is still in place in relation to our demand and capacity planning now for going into winter, and we are planning, as the third phase letter suggests and makes clear, we need to plan for possibly a reasonable worst case scenario winter, where we might see a significant second surge or numerous outbreaks, along with a worst case winter flu. Key to that, of course, is the response, both in relation to the ability for our system to respond with beds and staff and be resilient, but it's also the preventative piece, particularly around having a really good campaign for example, for winter flu. The third wave in any response is how we understand. So here we're focusing predominantly on COVID, on positive. Here we're beginning to think about, what about those people that have been shielded? What about the people who might have long-term conditions? What about the people who've had interrupted pathways because of the closure of services that we've seen? And then the fourth wave, we talk broadly around the wider economic impact. So the impact of loss of jobs, possible disruption to housing, the impact on mental health that we expect to see, the rise in domestic violence that we've seen, and so on and so forth. So this graph illustration, should I say, tries to capture the various aspects of a pandemic. And what we said in the system is that we want to follow these 8 tests to show, when we look back on this, that we've done well. So the 8 tests, the way we should read this is to say, these are the 8. So if we've got a good COVID infrastructure, and then if you go to the bottom of the column, this is almost like this is stated as an outcome. We know we'll have done well in relation to COVID infrastructure when we've retained our resilience to deal with an ongoing COVID-19 pandemic and ongoing needs. So we know, don't we, that COVID is not going away. It's around for a good period of time. There's been a substantial impact on the way we deliver services, on our capacity and on our flow and on our general staff resilience, which we continue to manage. For non-COVID urgent care, we know we've done well in this when we did everything we could to minimise the mortality and morbidity from non-COVID cases, which means that we've quickly got to rebuild our cancer diagnostics and our screening programmes and our services for people with long-term conditions. And in elective care, we know we've done well in this when we've prioritised the right access for people who require elective care. So this is ensuring that we've got the best access we can for people who are at risk of long waits, that we've addressed the backlog, because obviously when you stop services, and in our system we stopped 103 services, so we're this week beginning to get a much clearer sense of a system, in the whole system impact on what that means for our long waits and our waiting list. And then for public health, this is the wider, this is a sort of the point 4 on the graph. We know we've done well here when we've really impact on public health. So this is when we've got good joined up responses to domestic violence, to easier, better access for mental health and mental illness, when there's processes in place to deal with the economic hardship, and when we continue to understand and we all continue to comply with best infection prevention control compliance. So these 8 tests, I think probably the most significant in this that comes through really strongly nationally is equality. What we've seen nationally and what we know from our local system is that we haven't always been the best at making sure that our services reach all communities and all people. There's a real focus on thinking about inequalities. And then over time, this last column will disappear, because this is really, as we move towards becoming an ICS and working more and retaining the collegiality and the collaborative nature that we've seen in this space over the last few months, this, when we reach our ICS, will drop off, and then we'd have 7 broad areas that we could look back on. So when we think about the oversight and the changes that we've seen, we talk about triple lens. So this is how we think about the schemes that were set out in our NHS long-term plan, how we think about money and efficiency, and how we think about the contracts and quality performance. So the first thing we had to do and understand is when we stopped from COVID, what was the baseline? Where were we? What were the numbers? And we're pulling all that stuff together so that we're really clear on that, so that when we start again, we know where we're starting from. The other thing we need to work out is to understand what were the particular changes that happened, what was the good practice that we saw. So digital, I think, is a really good example where for a number of years we've been trying to encourage the use of digitalisation in this sort of format for applied to care, and it was a struggle to get people on board with that. Suddenly it's being used all over the place, which is really good, but we need to build that in and lock down those changes for the future. As we move on through our response to COVID, we resolve and build up our resilience. We've got to understand, and we're undergoing work of qualitative interviews with leaders and with clinicians and with citizens and with patients around what services have been like, capture improvements to make sure they go forward in the future, and then think through each of these 6 elements around the data and the understanding for pathways Clearly our challenge in the system is to have a workforce that knows that the system is a great place to work and understands the challenges and wants to address those challenges, but we also have a system that is under significant financial and quality distress. So those are things that we need to really continue to get to grips with too. It's an opportunity to rethink and reimagine how we want services to be in the future. An example of this is I chaired the Learning Disabilities and Autism Board this morning, and we, in this period, we're revamping, we're strengthening that partnership board. We're really using it as an opportunity to set out our stall for people with learning disabilities and autism to make sure that they get the best physical health checks for the future, and they get the best opportunity. And those people who are in care, institutional care, come back into our system as quickly as possible. So it's an opportunity to do stuff that we know we might not have been doing as well previously. This is a slide that really just says during any crisis, what would you want to amplify, things you'd want to keep and do more of in new practice? What were the things you'd want to stop and let go and not go back to? And what are the things that you want to stop that are critical, but you need to pick them up in some modified form? So that process underpins the way we're doing our evaluation and the way we're restarting. There's a couple of slides here just on, obviously, any system is driven by its people, and we often talk about organisations and institutions and the SDP or the STW, and it's us. And in this time, we've really wanted to focus on acute support for people, and to make our support not just during COVID but for all the time. So there is a system people plan that's focused on those most at need, particularly those from BAME communities, but also those staff that have been most affected by COVID. And this isn't just health staff, this is staff in nursing and care homes. It's people who are driving our hearses and be responsible for burials. It's people who are taking phone calls and receptionists. It's anyone that might be close to seeing the sort of trauma that we've seen during this period. So that the idea of trauma is being locked into our approach. We've trained, in the process of training up 150 people in an evidence-based model called TRIM, which provides routine support for people that are exposed to distressing circumstances and situations. I wanted to share with you some of the high-level principles that were in the plan for the NHS plan. So the principles were that we would work on these key aspects of strengthening primary and community care. So all the work around the care closer to home and the work around PCNs would be here. There's a big piece of work around hospital services. There's need to strengthen the voluntary and community sector. And ultimately, there's a real focus on co-production and bringing citizens into this. So there were some things that we'd said that we'd do, which was around listening actively with people, communities and staff, and work in partnership to transform our services. If you look at the NHS plan, it refers you to the National Voices, and there are 5 principles in that National Voices document that talks about tackling inequalities full on, don't leaving people behind, which is all about making sure that you are actively engaged as you begin to think about changing services. The other principles from March 2019 were really about sort of a program management with clarity of function, clarity of role, and clear accountability, which I'll show you in the last slide. So the principles for this time, coming through COVID, was that we'd work for virtual by default unless there's good reasons to be, and that's been supported by the national letter. That we want to build on the development of care pathways. So rather than think about each organisation individually, is to think about pathways across organisations. So the restore process that we've developed, in which I chair that group, there are questions. We have people from all different parts of our pathways and care, and we're asking about interdependencies, and it's amazing how interdependent our services are. Staff deliver services which rely on GPs, they rely on Shopcom, they rely on the third sector, and that's really been illustrated through this process. The other key thing is that we need to move towards population health management, and that we refresh the things that will help us deliver what we want, i.e. strong workforce and volunteer models, good estate, clear communication and engagement, particularly with citizens. And we think we haven't done as well in this area as we'd like to. This is something that's a real focus for us, because our services have changed and they're not going to go back to how they were. And we need to explain those changes to citizens so that they're really clear about what their expectations can be. This slide is a high level from the NHS submission last year. We never sort of described the model on one page. So this is an opportunity to an attempt to describe that. Effectively, our vision is that it's all ages. We want people to start well. Those first 1,000 days are absolutely critical. It's an understanding the impact of adverse childhood experiences on later life. It's when you're in life that you take everything possible that you can for self-care. That's good food, good eating, being deployed and employed, and that we live long and well at home for as long as possible. So,
Steve, could I just interrupt? I'm not being rude, but could I just ask you to summarise the slides, really, because you've only got 2 more left, haven't you? Just, yeah. I know there's lots of questions from the members for you.
Sorry, I can't see those. Yeah, so these 2 slides here are how, as a leadership community and as a whole system, we've worked well together. And this last slide is really how we move from where we are now in this place to the future, which is our overarching governance that links obviously to health and wellbeing boards, to joint HOSC, and yeah, I'll leave it there for questions. Thank you, Karen.
Thank you very much for that presentation, Steve. I've got Madge Shinton who wishes to ask a question.
Thank you, Chairman. That's not my dog, I promise you. My question really is, well, I want to say thank you to Steve, because I see the joining up of all the different sections as a major plus for something which has been quite unpleasant. I feel that we in the past have concentrated on the acute sector and perhaps community hospitals, GPs as well, but the domiciliary care for our people, which actually keep them from going into the acute sector, is important. And I feel that we need a little bit more emphasis, a little bit more information on how that's organised, what sort of training. The dog is obviously very angry, sorry. What sort of training is offered and how it's offered, what qualifications these mostly, but not always, ladies, because there are some gentlemen who are carers as well. And I would have liked to have explored that a little bit further, or perhaps Steve can actually tell us. Yes, we've picked up the domiciliary because they're all private companies, just the same as the care homes were, and that's where we sometimes have the difficulty of joining up the dots. So if Steve could enlarge on that a little bit, that would be good. Thank you.
Yeah, thank you, Madge. So we have offered support into the care home and domiciliary sectors, and the local authorities are key partners in this space with us. And the people system plan does pick that up. So you're absolutely right to highlight the important work that they do.
Thank you for that answer, Steve. I've got Dag Saunders and then Hilary Knight.
Right, thanks, Steve. That was a very comprehensive presentation. Covered enormous field. Just a few things. First of all, the phase 3 issue, the phase 3 letter, and with apologies to Madge, just to pick up some of the issues on the acute sector. It looks pretty challenging. I mean, I think the 3 items I picked out are the 90% of the 80% last year day case by September. 90% CT MRI scans by September, 100% by October, and first outpatient tenancies follow-ups virtually or face-to-face by September. They look pretty massive challenges. I know there's been a lot of discussion across the NHS about how people think that they're going to be able to meet those. So how do you feel that they can be met? Because clearly there are things that the general public will be very interested in, but as I say, they do look pretty challenging. Can I then also pick up the issue of the use of digital consultations, which I think is at last we're getting the NHS in the 20th century. But there are, of course, significant parts of the population that don't have access to digital technology, often older people. There's reference to GPs that are moving to the virtual consultations only. Do we know what percentage of practices are moving in that direction, and what those practices might be doing to ensure that patients who don't have access to digital technology can also contact the GP? Third issue and final issue that you referred to, which is basically staff burnout. It's something that obviously been talked about a lot. Have you been able to assess what the issues are in relation to staff fatigue, what is it particular types of staff, and whether there's anything that can be done to help those categories of staff that we all know from all the national publicity have suffered in greater ways than others? Thank you.
Can I invite Nigel maybe to respond to the electives? It might be sensible just in terms of the impact from compliance with IPC, and you might want to pick up the staffing issue as well in terms of resilience in SAF, Nigel.
Thank you.
Yeah, thank you. Sorry I was a couple of minutes late. So just in response, and may I deal with the staff first, if that's okay? I think, and to be fair, this is something that again we've worked on as a system. You know, there's a number of people that have been impacted across the sector, and whilst I would, you know, certainly focus on A&E, critical care, and certainly those individuals that have been working on the actual COVID wards, where obviously the pressures have been significant. Then obviously there's a huge amount of people that have been working so hard. I think again one of the highlights for me is all the work, as Steve has mentioned, on with the local authorities and community teams, because our discharge rates are significant and one of the best in the country to get you know, to avoid people waiting in the hospitals and getting to a better place of care. So it's significant. What we are doing though is we've got quite a detailed package of work of psychological support. The Mental Health Trust have provided us with some expertise, supported by some other companies. But our workforce team, but also this is being coordinated, are working quite carefully across some of those teams, deploying it to some of the priority areas, and that's both on an individual and a team basis. I think the other one, which kind of links then to a certain extent about the elective side, is genuinely, and this has come all the way from the chief exec of the of NHSI and chief operating officer as well, Amanda Pritchard. That genuinely is, you know, at the moment we're in the summer, you know, we do need to make sure that our people take appropriate leave and have a chance to recuperate as well. So that is being pushed. But I think we are acutely aware that, you know, keeping our staff safe, we've seen an increase in the pressures on people. So absolutely, we need to keep supporting. And I think we're again all acutely aware through the media and national that the potential for a second wave means that again we just need to keep alert to that. On the elective activity, and again as Steve's alluded to, a number of services, and certainly most in the acute sector, have been fundamentally changed by a post-COVID era. We see that every time we go to the shops and others, let alone in other places. So our outpatients, we need to make sure that we've got appropriate distancing, and that is affecting the throughput. Our imaging, so our CT and MRI and endoscopy, again, we need to make sure we've got appropriate IPC precautions taken between every patient, and obviously protecting the staff, and the elective side in terms of theatres themselves. So it will be a significant challenge to get to that 90-100% of pre-COVID, and We're working, certainly I believe Dave Evans is on the call. Dave and other system leaders have been working hard with NHS Improvement and others about how we access additional capital, additional support, and also work across not only our system but also with people in the region. And I'll give you a good example of, for example, the West Midlands Cancer Alliance. When we're looking at if we haven't got the capacity, how do we make sure that we work together across wider borders? Does that answer some of that for colleagues?
I suppose, can I just interject just quickly? If you don't reach these targets, what's likely to happen?
That's a really good question, Karen. I might invite Dave Evans to help me on this one. I think the first one is that we're committed to not looking at this at an individual organisational level. We're looking at it as a system. So this is about how we optimise everything across our system. I think the second bit is that as a system, if we are challenged, then we need to work as certainly the West Midlands, as a region. So I think what we would do is continue to look at every single option for doing that. In terms of the other implications, then I think that is still to be developed. I think Dave's got his hand up and probably would have more insight than me.
Thanks, Nigel. I mean, as Nigel said, this is an incredibly challenging time to be trying to restore services fully at the same time as, of course, we've got winter coming. My hand doesn't want to go down now for some reason. Sorry, Karen. We're really committed to delivering this target. We don't know what will happen if we don't, although I'm sure we will be under increased scrutiny from regulators in terms of NHS E&I. We are, as Nigel said, working across the system. This isn't about SATH delivering the target. This is about the system delivering the target. We will be continuing to use the Nuffield as part of our solution to deliver the whole of the elective agenda as we move forward. I'm more comfortable that cancer, with the caveat that Nigel's put in about using Cancer Alliance where necessary, will be easier to achieve. We will get as close as we can to the others. I wouldn't wish to say, give a guarantee that we can, although that clearly is what we will be working towards, because it is incredibly complex and incredibly challenging. If I pick up Dag's point about GP Digital, all GP practices by next April have to offer online consultations for patients, but that's not the only option available for patients to have a consultation with GPs. The phase 3 letter talks about primary care in some detail, talks about the continuation of telephone triage, talks about the ability for patients to have face-to-face consultations if required. And I think that's important to remember that all GP practices will be moving back to having some face-to-face consultations for those patients where a face-to-face consultation is necessary. But there will still be digital consultations, telephone consultations, and face-to-face when required.
Dag, did you want to come back? You're on mute, Dag.
Right, yeah, it was going wrong. No, I think you raised the most important one, and clearly it's, as Dave said, it's very challenging, but we do have to keep eyes on the fact that the message cannot go out that you can only contact your GP digitally. And I'm sure that won't be the message, but we do need to keep eyes on that. Thank you.
Okay, Hilary.
Thank you. Steve, you mentioned in your presentation about winter planning. I think as a committee, we'd be very interested in learning more about the winter plan for this coming winter. So I wondered if you could tell us how far down the line you are with that and when you'll be able to bring it to committee. And also wondered how the reduction in beds because of COVID will be affecting your winter plan, because we're sure it must be. Sorry, and then I do have one more question on the current use of bought-in capacity, particularly Nuffield. If it's not being used to its full capacity, why is that, and what are you doing about it? Thank you.
Thank you. So we have the basic elements of a winter plan, which is being led by our winter plan. And in fact, we've got a long conversation about it this afternoon in our System Silver group. There's a key challenge, I think, which is to align the winter plan with restoring services, and also with refreshing our system plan. The impact of bed deductions is critical, but of course there are a number of elements, including, for example, we're going to be the second pilot in the Midlands to roll out a new initiative where people will be encouraged to talk before they walk into ED, to make better use of NHS 111. One of the key things is to have a strong suite of community services that manages demand better at the front door, that starts with good case management so that those with long-term conditions are properly assessed and identified and encouraged to work, and where people, as Nigel has already alluded, where people end up in hospital, that they're very quickly discharged. So it's about sustaining those aspects. But to go back to Karen's question, I think what will happen? What will happen, of course, is that people will experience harm. And we can't pretend that we have a system that's going to go back to where it was pre-COVID, because it can't. In order to comply with our infection control guidelines, we have lost beds, our processes are slower, and our estate is very challenged. So we know these are some of the elements that we have to manage and that we're grappling with. And I think that's the message that we have to be able to articulate to people, so that people understand and know that they can access services when they are critically unwell, understand the things they can do to keep themselves as well as possible, and then know who to access, i.e. through NHS 111, for some of those routine inquiries that might come about when people begin to be, to feel a bit wobbly or a bit unwell, for example. I mean, the impact we have, we are working very closely with colleagues in NHSEI. We've just got some additional capacity for the next 3 weeks to help with some of our screening, and we've requested additional support for wards and modular capacity. We're still waiting for that to come through, but NHSEI understand where the situation is on this system. So I don't think there's going to be any heavy hand of legislation or authority coming down. It's more of a how can we support you conversation that's in place.
Have we heard correctly, though, that some of the initial lump sum of money that was put to one side has been reduced to help and smooth some of this transitional work going forward through the COVID crisis? Is that true? And also, you've described a very collegiate way of working within our system. Are you confident that should you have to go outside of our system, you will have that same amount or degree of collegiate working?
Do you want to pick that up, Dave?
Shall I come in, Karen, if that's okay? And just picking up a couple of the points from Hilary as well. If I do those first, and then I'll come on to your points, if that's okay. It might be helpful if we try and articulate some of the scale of the challenge here, both in relation to restoration in terms of the phase 3, and also in terms of what winter may or may not look like and how that impacts. Specifically, SAF are down by about 75 beds because of social distancing. So that's quite a significant percentage against their overall bed base. So immediately we've got a reduction in capacity because of beds. We've also got a reduction in as a system, a reduction in productivity because of the increased requirements around infection prevention and control and the length of time it takes for people to change PPE. So if you look at things like theatres, endoscopy, some of the other diagnostics like CT and MRI, we're probably running at, I would estimate, Nigel may correct me, about 50, possibly 60% of pre-COVID levels because of the increased adherence necessary and the increased requirement necessary for infection prevention and control and change into PPE. So both of those make a significant reduction in the overall productivity of the system moving forward. Hence why we have put a significant ask into NHSEI around modular capacity in terms of beds, in terms of diagnostics, in terms of theatres, not just at the two SAS sites, but also at Robert Jones and Agnes Hunt, to get us back to those kind of productivity levels and replacing the bed base we lose to enable us to get closer. Now, we haven't heard whether that's going to happen yet, so I do need to stress that. We are continuing, we are using the Nuffield, but again, the same constraints, particularly around productivity, are as true there as they are in both Sath and Robert Jones and Agnes Hunt in terms of time taken between cases. And to put it into context, again, I think Nigel will correct me if I'm wrong, I think CT turnaround times previously between patients were between 5 and 10 minutes. They're about 30 minutes now. So you can just see when you spread that out over the day, how much of a difference that makes to the number of patients that can be seen and treated. But we are using the Nuffield. We will be committed to continuing to use the Nuffield. And I know Julie Davis is talking to the Nuffield today to mark out exactly how much capacity the NHS can use there over the winter period moving forward. Karen, sorry, I've forgotten the other point you raised.
It was about your confidence in the collegiate working continuing once you step outside of the system, and also what has been heard about the reduction of this pot of money that's going to be available. Is there any fact to that?
So in terms of the collegiate working, we've already been having discussions. We had discussions early on in COVID with colleagues in Staffordshire around critical care and the possibility of mutual aid in critical care capacity across the two systems. I have written to counterparts in Staffordshire, and I know they were discussing it this week, about mutual aid agreement moving forward as we move through the next phase and into winter. And I'm expecting, I'm sure there'll be some alterations to the draft document that we issued, but I'm sure that they will want to enter a mutual aid agreement. So I'm fairly confident, actually, that spirit of collaboration and cooperation and mutual aid will continue. We've not heard directly in terms of capital, in terms of any reduction, but what I would say is actually we put forward a substantial bid for this system. Most other systems put forward a substantial bid as well from the ones I've spoken to. I can't imagine they're all going to be funded.
Yeah. No. I suppose as well, it's the thoughts of, okay, at the moment we're in crisis, but as it would appear that there's a likelihood that this could go from crisis to chronic. And I think the impacts then on the system will really come under pressure and will show different pressure points and weak areas. But I suppose you just have to deal with things as they progress. But that's my thoughts, that we could go from crisis to chronic, and then what? But I've got Madge wanted to come in and ask another question.
Thank you, Chairman. You covered cooperation with Staffordshire. What about the cross-border with Worcestershire and Herefordshire, which, as I'm in southeast Shropshire, most of my flock go in that direction. What sort of cooperation do you have with them?
Thanks, Madge. And yes, I do know the area you live in quite well. We have had informal discussions with the Worcestershire Herefordshire system. I've had informal discussions with the AO down there. They recognise the cross-border issues that do flow both ways. And although we haven't got a formal mutual aid agreement in place, I don't anticipate there being any significant challenges. I probably should add, of course, also in relation to the Welsh border, we have active discussions on a very regular basis with Powys Health Board. They are one of the members of the Silver Group that Steve was talking about earlier, and I have regular communication with the Chief Executive at Powys Health Board. So at the moment, we're not experiencing any cross-border issues with any health partner in whatever system, and I'm confident that's going to be the case moving forward.
Okay with that, Madge?
Sorry, I switched myself off straight away, Chairman. Yes, thank you very much. That's helpful. Thank you.
Just to sort of draw a line under this, thank you very much to everybody who's attended and for your contributions and your work. It has been immense. We can all recognise that, the scale of the challenges you faced. Could you just give us a brief summary, though? I think this is probably for you, Nigel, around the activity of A&E and the differences. What have you seen sort of pre-COVID, the height of COVID, now we're going in? What's the activity levels like in, if you can separate PRH and RSH?
Okay, yes, certainly. As colleagues in the hospital know, this system has been under significant pressure for the last couple of winters. And I think that just reinforces the points that Dave's mentioned there about how we work as a system and all the admission avoidance and one-on-one points that Steve made as well. So we're really focusing on that. During COVID, in line with many other organisations and across the country and in Wales as well, we saw quite a significant reduction in activity. What we have seen, again, in line with many others, is that recover and rise back to about sort of 80% of what it was. What we are seeing across Shropshire and Telford and Wrekin is a little bit of a disparity. So we have seen the activity, and especially the ambulance activity, come back to at or slightly above pre-COVID levels. And at the Telford side, it is still slightly below. So we've got a little bit of a disparity across the two at the minute. Now part of that is that we have, and as colleagues will know, we have at the minute temporarily moved our trauma service to Robert Jones. And we are cycling all trauma ambulances through the Royal Shrewsbury to stabilise patients and confirm anything else required before then onward transfer. But that only is a small proportion. So we are seeing quite a difference. So we're keeping a very close eye on that. There is something around the age profile which we've looked into, but it's probably more complicated than that. So we are keeping a close eye. I think the challenge as we're looking ahead, and again, as Dave has mentioned, is, and as Steve mentioned about winter planning, is how we look ahead and make sensible judgments on what we believe winter is going to be, and with or without any potential for a second wave.
What are the waiting rooms looking like with socially distancing in place?
Again, for any colleagues that live either next to Telford or the Shrewsbury, the Telford site is bigger. So the A&E department is bigger geography, and that is an area that is still okay. We're working very closely with patients with masks and other things to make sure that we've got that as carefully as possible. The Royal Shrewsbury is more challenged, and certainly my teams and the health and safety are working very closely, to a certain extent not dissimilar to how we're trying to manage the outpatient waiting rooms, to make sure that we've got as much social distancing as possible. We are also reviewing it because as activity has started to rise, then we need to consider whether or not we have, how do we limit relatives coming with patients, etc., and how we do that. I know other places have been slightly stricter. So we are keeping a close eye on that, and it is an area of potential risk that we need to monitor.
Absolutely, especially as we go into the winter and the colder weather, you can see queues of people snaking outside, you know, socially distancing, waiting to get into the A&E.
Yes, and I think one of the other elements was that again, as colleagues will know, we have again temporarily moved our urgent treatment centre facility, so with the primary care GP and an emergency nurse practitioner, out to both the Whitchurch and the Bridge North MIUs. The Bridge North has actually seen quite a significant rise, and then, you know, are working together with the community team and a couple of others, I think, has been quite successful. Arguably, Whitchurch has seen less activity, and that might be because of, again, the geography. So with Dave's, one of Dave's team supervising, we're working through what the next phase of that. And the reason I mention that is the whole intention was to make sure that we were avoiding unnecessary people coming into the main emergency departments. That was the primary objective for safety and care. So we're keeping a very close eye and monitoring that and deciding how we make sure that we make best use of the clinicians versus make sure that we balance patient care and safety.
Yeah. Right, well, thank you very much for that reassurance and those answers. Thank you very much to Steve, yourself, Nigel, and Dave. Dave, I think are you staying on?
I am, Karen, yes.
Okay, so thank you very much, everyone. So we now move on to the next item of the agenda, slightly later than expected, but welcome back, Kate.
Thank you. And I am slightly an imposter, as Steve mentioned, as it was meant to be Pam who was going to take you through this presentation today, but unfortunately she's been called away quite urgently. So if you bear with me, and I'll take you through it. So the communications and engagement for Restore and Recover. We've done a number of key pieces of activity, and we've developed 2 key communications and engagement documents to support the Restore and Recovery work. We have a draft communication and engagement strategy for system restoration and recovery, and this is an overarching strategy, which is in addition to the refreshed STP communications engagement strategy. It's underpinned by various communication plans which are developed for the service changes, for potential outbreaks or significant increases in cases. We've also carried out a piece of work to draw together the different elements of engagement that have already happened across Shropshire, Telford and Wrekin. And this has taken into account the feedback that's been captured by both the health watchers from their surveys, specifically gathering the views on services and the use of services during the pandemic. We've also gathered the feedback that's been received by the PALS and complaints services. So in terms of stakeholder and system engagement, very early on in COVID, we established the Communication Task and Finish Group, and this initially came together. It was meeting 5 days a week and had representation from all of the organisations within the SDP footprint. Now, this was to ensure that we had a joined up system-wide working across all of the comms and engagement teams, and it continues to meet weekly on Wednesdays. This has been really important for us for flagging and escalating any issues, and we've been able to share updates across the system and key messages to maximise pushing those messages out to our different audiences using all of our different channels. These meetings feed into the communications and engagement sit reps that go to Silver and Gold Command, and the Restore and Recovery Communications is now a standing agenda on this meeting. We've got comms and engagement leads who are aligned to and providing support to each of the system-wide task and finish groups, and these include things like the care sector group, community resilience, testing, PPE group, and they're providing input to the system restoration and Silver and Gold. We've ensured that we continue to work with both Health Watch and the voluntary and community sector throughout, and this is including getting membership on the Integrated Care System Shadow Board, on the System Restoration Group, and sharing information and key messages when appropriate. We're also looking to build on the work that's already been developed by the integrated approaches to volunteering programme. So we want to learn from the progress that that programme made, and also using our collective experience over the last few months to develop the work. We've been having regular briefings with MPs, and these are currently on hold for August. And we've also been meeting with HOSC chairs and attending the full committee meetings. We've had regular communications going out to GPs, and these have been written updates and including the key messages outlining the changes to services and the services being restored, and making sure that the communications are out around the their openness to referrals.
Can I just interject on that last slide, Kate? And that is just to clarify the meetings that you've been having, or Pam has been having with the chairs and the joint HOSC. These are informal information sharing meetings. They were not formal meetings of the committee.
Okay, that's fine. I'll take that back to Pam for you.
Thank you.
So moving on to public and staff engagement, both Healthwatch have carried out a public survey to understand the impact coronavirus has had on people's experiences of services. We've promoted those across the system using all of our channels. We've also factored the findings into our communications and engagement strategy, and those findings will help to influence our future engagement. We're also encouraging people to respond to Healthwatch Shropshire's current hot topic on virtual consultations, and we'll continue to work with both the Healthwatches on any future communication and activity. SAF have established a virtual public engagement forum where they've been using Teams, giving people the opportunity to hear updates from key speakers, to ask questions and to provide feedback. And we've put together an informal engagement group, which is meeting weekly, looking at different solutions for public and staff involvement in place of face-to-face, but also mapping the different groups, particularly seldom heard groups that are meeting virtually where we can link to. So we're very much aware that we want to be able to put in place ways of engaging with people, and as we would have done previously, going out to those groups where they physically met, we now need to establish where they're virtually meeting so that we can reach out to them and access those groups where they're already coming together. All of the different organisations are sending regular staff updates, and those are going out by email, and they're also virtually holding events. We're providing key system messages from gold and silver for all of the organisations to issue, and that's very much a system-wide approach. The different organisations are crafting and issuing communications where services are coming back online, but they're also working with other communication colleagues where there are interdependencies. For example, those might be referral pathways that cross over different organisations. All of the organisations have been proactively and reactively doing media interviews throughout the last few months and issuing press releases and statements to reassure the public. For example, Anna Rose from SAF has had a weekly column in the Shropshire Star and a weekly slot on Radio Shropshire. Press releases have been shared with communication colleagues and both Healthwatch so that we can maximise circulation. We've also been using social media a lot to push out messaging and communications, and communication colleagues and stakeholders have supported through retweeting and sharing wider. So we just make sure throughout those communication and engagement task and finish groups, we share any upcoming communications that are being shared so colleagues are aware and are able to support in pushing those out further. So our messages of reassurance have included services being restored with safety, with staff capacity and potential for outbreaks and surges in mind. Services are available, but your experience will be different due to social distancing. And we appreciate patience and understanding as we prioritise some patients and procedures. So those are the key messagings that we keep reiterating as we currently go through this. Our current areas of focus include outbreak planning. So we have communication and engagement leads from NHS and system represented on the Public Health-led Local Engagement Board. And we've also taken the learning from Leicestershire through the Regional Communications and Engagement Network. And an update is provided by the Council Communications team on the Comms and Engagement Task and Finish group to ensure that all the partners are kept up to date. So we have that as a standing agenda item at the moment. The council team are also completing a daily sit rep, the communications team sit rep, and circulating it to all of the comms colleagues across the system. And we've been working really closely with public health colleagues to engage with specific groups. We're also focused on the restoration of key services like cancer. We're using the national materials to support the work and explaining the new ways of accessing services and what people can expect. We're continuing to reassure people that certain services are open, particularly where we've picked up on some specific needs. For example, reassuring people, as Steve mentioned earlier, around GP appointments, so that face-to-face appointments are still available. And we're now looking at services that will be recovered and the need for engagement around those. So reaching and involving communities, each of the services being restored has a quality impact assessment to identify the impact for the different groups. There are challenges of using certain virtual platforms for engagement now. So we're looking at different solutions using existing resources and opportunities, and also looking at new solutions to help us to do that work. We're listening and learning from the feedback that's already being captured and continues to be captured across the system, and by the system and by key stakeholders, so that we can develop appropriate surveys. We're mapping where and how different groups are coming together, as I mentioned earlier, so that we can go to them rather than expecting them to come to us. In all of our work, we're thinking about the implications across the borders and linking in with colleagues when needed. And we've been working with faith groups in the communities so that we can reach out to those different groups and develop messaging and materials which is suitable and appropriate for them. There are also a number of interdependencies that we have to consider, and these include the wider system working through ICS Shadow Board and implementing oversight group. We've also got to factor in the planning for winter and the rollout of Think 111, whilst supporting national campaigns. So that's the completion of the presentation. So I can attempt to answer any questions, but if there are any that I'm unable to, I'm happy to take them away and come back.
Thank you, Kate. That was a very, very comprehensive run through the work that's taken place over some period of time, pre-COVID, then during COVID. So thank you very much for sharing that with us. I can't see any questions coming up on my chat. I'm just going to ask colleagues, do they have any particular questions for Kate to take away or maybe answer? Dag.
Yeah. I think it's been covered, particularly in the last slide, but nationally we do seem to have a big problem trying to get the message over to age groups, I suppose about 14 to 30 odd. Is there any specific work that's taken place with those particular groups, and you know, where they might gather, or social media that they use more than others? And also the issue again, which was mentioned in the last slide, but can you tell us what specific work's been taken place with people whose first language is not English, particularly the BME communities?
Yeah,
okay. Are you able to answer those?
Yeah, so in terms of actually both of those pieces of targeted communication, we've been working really closely through the councils and using social media, particularly for the younger age group, to target communication in places where they are accessing that information, to try and encourage those kinds of grouping and gatherings not happening. But in terms of the for communities where English is not the first language, again, working very closely with faith groups and different groups within the community, where they've been helping us to develop translated materials which are suitable for their community. So there's been a lot of very, very successful work ongoing with those groups.
David, did you want to come in on that point?
It was just to give some information which may be helpful, Karen, because I've not had an opportunity to talk about this before. As you will be aware, the two CCGs have been advertised recently and have appointed for joint board members, joint lay members to the boards of both CCGs. We actually have included now within the board of the two CCGs a lay member for inclusion, diversity and inequalities, because clearly, both in terms of our local population, but in the wider NHS, inequalities in particular, and the extent of the impact on COVID on certain sectors of society is an increasing focus, and we wanted to address that.
That is good news, David. Well done. I've got Janet. Janet, you wanted to ask a question?
It's really for information. Health Watch Telford Reekins COVID-19 impact survey is not available at present. It's going through moderation. Okay, that's it.
Okay, thank you very much. And you'll be sharing that presumably as soon as it's been moderated. Yeah. Thank you very much, Janet. Thank you, Kate. There's no more questions. So thank you very much. Would you take that back to Pam? I'll be speaking to her soon, I've no doubt.
All right, thank you.
So thank you. We finished that one slightly early. I don't know if we have our next presenters, Dr. Jane Povey, Julie Davis, with us, or whether we want to take a 5-minute break. Are you with us, Jane or Julie? They were not due to be heard until 3:20, so I think we could probably. We could either bring forward the co-chair's update, or we could take a comfort break, whichever people would prefer. Any preferences?
Keep going, Karen.
Keep going. Okay, right. We'll do the co-chair's update.
Yeah.
So this is keep going. We'll do this then. Derek, we've just got 2 updates, really, haven't we? We've been having these informal meetings throughout the last 2 months, really, with various chief executives and what have you across the system. And we had one just recently with Neil Carr and Kathy Riley of MPFT. And it was a very productive one, I have to say. Mental health has not come under much scrutiny over the last few years, and it feels quite timely to bring it through. And they've agreed that they will come to our next meeting, and we'll be looking at sort of 3 areas to begin with. But that's not to say they will just be coming to 3 meetings. This could spread over a period of time as it evolves. The first one, we're going to be looking at CAMS, the Service for Young People, and then we'll be looking at the transition from children's services through to adult services, and then the third piece of work that we'll be looking at is adult mental health care. Derek, did you want to add anything to that?
No, just regarding the meeting with the Health Watch, and basically we have agreed that we're going to be working much closer with Health Watch, sort of coordinating the what they're doing with what we are doing, but they are able to look at one side of it where we can look at the other, and it's actually about sharing the common problems. It's also about having much more regular meetings. We haven't, as a HOSC, actually done that in the past, and I think it's a real error, and it is a part of actually the policies that we're putting down of actually, you know, setting aside all our differences and trying to concentrate on what is good for Shropshire and health. And we can only do that by actually working together. We expect the health communities to work together, then we should also be doing that. And we're also looking at reviewing what Scrutiny is doing and the way we are. And it is a question, who scrutinises Scrutiny? So we need to look at how we are doing it, and how we can do it better, and how we can do it more in working with the health community and getting the information that I think that has been sadly lacking in the past.
Well done, Derek.
Yeah, I absolutely agree with that approach. And, you know, both of our health watches are a mine of information and data and intelligence that, you know, we really haven't used them as well as we could have done. So I'm hoping that, you know, the future will be brighter by their input, and it adds to our capacity as well to be allowed to be able to have access to that kind of information to formulate our questions, if you like, and to give some evidence-based backing to the questions that we ask. Hello, Jane, you've just joined us. Welcome.
Hello.
We finished the last item rather early, so we've just sort of brought the co-chairs update forward to allow time for you to join us. I don't know. Are you ready? Is Julie with you?
So she's also at another meeting. So whether she can join just now, but I can start off anyway. In fact, that was the way round. We were going to top and tail it so that I'd start. So yes, she may well have just seen Joseph's message as well, but I know she's actually in a meeting, whereas mine had just finished. So
okay, that's super. Are you able to share your screen?
I can do, yes. Just bear with me. Well, saying that, let's hope so.
If you can't, I'm sure that Joseph or Daniel will be able to help.
Okay. Oh,
there
we go. I might be in luck. So what I'm going to do is try and put it onto a slideshow, but that means I can't see you, or well, I can see yourself actually, Karen, but I can't see if people are trying to chip in. And I'd really very much like this to be a discussion. So please interrupt me.
Well, what we've agreed to do so far is to allow the sort of the connectivity of the broadband, or I don't understand these technical things, but it would appear that if everybody is on screen and have their microphones on at the same time, it reduces and interferes with the streaming of the of it. So what I'm using the chat, and people just come in and ask, you know, say can they speak, and you're happy for them to interrupt.
Absolutely, I'd much rather that. I mean, essentially I've been asked to come today to share with you our thinking around a system end-of-life review, which I know is something that you yourselves are very keen of happening, but what I'm not doing is coming in and telling you what we're doing. I'm really hoping to discuss with you how we can co-create it and shape it together with yourselves, but more than that, our public, patients, carers at the heart of how we do this. So any chipping in would be very welcome.
Okay, that's a really refreshing approach. Thank you, Jane.
Has the slide moved on to the background one? Because sometimes they get stuck, don't they? Have you now got?
It's still on system end of life.
There you go. And I thought it was going so well. Let's just see if that works.
It's moved now, Jane.
Has it moved? Maybe it just takes a bit of time. So you're on background now?
Yes.
Super. Is that Dave there?
It is.
Ah, fantastic. Hello, I didn't know you were there. Right, that's super. I won't be rude then, that's fine.
Be as rude as you like, Jane, it doesn't matter.
No, it's great you're there. Julie's joining us, but I thought it was worth, are you happy that we just kick off anyway?
Yes.
That's great, yeah. So essentially, there were a number of questions that Jill George raised to both the CCG and Shropcom boards a couple of months ago, and they were with respect to the way end-of-life care is planned and provided across Shropshire, Telford and Wrekin, and also some more specific freedom of information questions around the contracting of primary care out of hours provision, in particularly with respect to end-of-life care. In addition to that, the discussions that ensued because of those questions, because the questions were responded to and the FOI questions are sort of being discussed and there's an ongoing discussion and information sharing there. It appeared that it would be a really good idea to consider a broader system end of life review. And Karen, at that point, you emailed me as well, and there seemed to be, and some of your colleagues, and there seemed to be a collaborative appetite for that. It seemed to be an opportunity. Just a conversation had arisen. We recognised that back in about 3 years ago, as a community trust, because I mean my role is both medical director for the community trust, but also clinical chair for the STP system. But within our community trust, we had recognised, in part on the back of a CQC inspection, but we'd recognised that there was more to do around end of life care. So you'll know Kath Molyneux and Karen Stringer, who produced our end of life strategy, but that is 3 years ago, so that's being refreshed anyway, and it seemed to be a really good point to look at this as a whole system and to involve you with that. We're also aware that there have been some concerns raised around the quality of respect forms at SATH, and we're I will come back to this, but we've been doing a lot of work around advanced care planning, including respect forms, and we're recognising it's not just SATH, but these are not being done to the best quality across the whole system at all times. So that's another reason to do this work. Healthwatch have just done a really helpful survey around, it's not that long ago, it feels, well, it's another world, isn't it, January, but it's not that long ago, and that presented some positives and then also some learning, and then the CCG, so Dave on behalf of the CCG and David as ShopCom Chief Exec are very, very keen to take a lead on this review. So we want this to be a very high level but public focused approach to where we are now and where we want to be around end of life. So as I said, this is really, I'm hoping that this is a discussion to shape how we do this. We don't have a fully made plan, but we'd like to involve you in that.
Thank you. Lynn, you've just popped up on chat making a very interesting comment.
Hello, yes. So it's sort of following on from the report that was published in January this year, where we were approached by the CCG and ShopDoc to do that piece of work around palliative care, particularly out of hours. And so ShopDoc have approached us again to get some feedback on the palliative care helpline that was set up at the beginning of lockdown, to try and get some feedback on how that's been working.
That's really helpful.
And it will cover Telford and Wrekin. It's just that on this occasion they just wanted there to be one survey that people could be directed to make it as simple as possible. But our colleagues in Healthwatch Telford and Wrekin are supporting us with that piece of work.
What's the timeline on that, Lynn?
I haven't got that to hand, I'm afraid, because I've not been leading on developing the survey itself. So we've been working with ShopDoc and some GP members to agree the questions that are going to be asked. Okay.
Thank you for that, Lynn. I think, Jane, you know, what is really refreshing, as I say, is that you're looking at this as a whole system, because what has become apparent, you know, when we hear anecdotally issues around end of life, is that it's quite often the movement through the system. It isn't a smooth move, if you like, through the system. It is disjointed, and it's when you try to move through the system that's when the issues really occur. So that you're doing it across the board and involving whether it's ShopCom, SATH, CCGs, and having a joined up, if you like, pathway. Because I think, was it Janet? I think, wasn't there something that you mentioned about advanced advance care plans from homes. Janet, would you like to come in on that point?
Yes, I would. It's a recent experience of someone end of life care who had a respect form, but then when they returned back to hospital again, another respect form was done, but the consultant wasn't aware of the advanced care plan because it hadn't come from the home she was at. So there's a problem there of it doesn't follow the patient, and really it should all be joined together. That's my question. Why isn't it joined together?
Yeah, absolutely. So I was going to come on to a bit more about what I'll do is just move on. Has that slide moved on to what we've done as a system so far?
It's still on background.
Let me just wait. Sometimes it takes a little moment. So I can answer the question around, let me know if it, otherwise I'll go back and I'll go back.
It hasn't changed.
No,
Yeah,
that's fine.
There we go.
There we go. It has now.
As if by magic. Okay, so essentially respect is, there's a few parts of respect. It's the recommended summary plan for emergency care and treatment. So it's essentially a summary of what has been agreed both with respect to DNA, CPR, but in addition what's agreed with respect to anticipatory care planning more broadly. And it is only a summary document, so you would also at best expect a more detailed anticipatory care plan to come with it. So what's happened across this system is that there has been an end-of-life strategy group across the system that has been in place for some time now. It actually, when the STP formed, it was the only clinical system-wide group that was functioning to any great extent. And it's very much made up of the enthusiasts and experts from absolutely every bit of the system: social care, health, primary care, the hospital, the hospice, and they agree. I'm actually just going to, well, I'll come back to that actually in case the slides don't move, but they agreed a strategy on a page which was sort of as a system at a high level, what can we do? And the thing that they prioritised was respect, because I think they could see what you're suggesting, Janet, that things weren't working particularly well with respect to the documentation around end-of-life planning. So last October, there was the implementation across our whole system that respect forms were the way to do it, because otherwise, if you imagine, there could have been a different set of forms from every bit of the system. So the first thing was to say, let's have one way of doing this. And then absolutely, as you're suggesting, it should be with the patient. There's only one copy, it travels, and within primary care, it's digitalised as well. So through summary care records, that's going to open up a much more, you can see how that will help, because we're all going to be able to access summary care records, whatever bit of the system we're in. But we're not there yet. So that ambition is there. And you're obviously highlighting an example where it didn't work, Janet. So I think that is a really good example of where this review can look at what we've got in place and what's missing. But it is positive that we've got full system buy-in to that, and this is because of the system end-of-life approach. The next thing I was going to mention was just following on from what Lynn was saying. So it was recognised, and I was talking to Derek Willis, the medical director for the hospice this morning, when COVID started sort of to be more of a problem. 111 were not very effectively managing to direct people that were end of life to the best help that they could get. So Shropdoc worked with the hospice to sort of, as it were, bypass that and just open a 24/7, both professional but also patient-facing access. So that'll be great to have that evaluated. I suspect the problem there is not everyone knows about it as much as the evaluation if you do get hold of it. The other thing that we've established is a single way of documenting end-of-life care plans. So as I say, respect is only one bit, but clearly once people are needing an end-of-life plan, it's best practice to make sure everybody's writing in the same document, every member of the team, and that it's the same document in every bit of the system. So we have agreed one that should eventually find itself in wherever you are in the system. And again, that's not effectively implemented, but it is there as a, you know, something that we're working on, and the plan is there. And then the other thing that was being worked on by this group, how we ensure that every patient and their family have the opportunity to have a discussion around how they want to be cared for. Now, advanced care planning frameworks, they're quite difficult. It's quite a sensitive sort of topic. It can be discussed quite negatively if you start talking about ceilings of care and what's not going to happen. But actually, very simply, this is around understanding whether, firstly, resuscitation would not actually help the patient because it wouldn't improve their outcomes. And secondly, what is it that people do want and what do they not want, and that's clearly documented and then followed. So we now have a system-wide framework. It's visible it's published on the hospice website, and lots of tools so that staff can help, can understand how to do that well and to get support if they're a little bit unsure about that. And we've got a team, a task and finish group with implementation groups, making sure that whether you're in a care home, you're in your own home, you're in hospital or elsewhere in the system, that the people around you, the staff around you, can help you with advanced care planning. So, I mean, for all of that, and from the conversations that both Jill and yourselves have sort of started, which is leading us to this discussion now, end-of-life planning and care is a system clinical priority. We are just agreeing the sort of governance around that at the moment, and it's likely that David Stout, with his community and place-based programme board, will be making sure, you know, overseeing the work around end of life, so we can be assured that this is something that will be prioritised and delivered.
Can I just interrupt you, Jane? I can't tell if it's Derek or Daniel, Derek White or Daniel Webb that wants to ask a question.
It's not me.
Oh, it's not, Derek.
It's not me, no.
Oh, your hand's up, Derek.
Lower your hand, okay.
Okay.
Sorry. I just like being noticed.
I'm sharing this you won't be able to read. I'm very happy to share. You know, you've got these anyway to read, but I just wanted to demonstrate this is our system-wide end of life plan on a page. You can see all the icons around where it's very much in partnership, and it just demonstrates this is where respect was picked up as being one of the significant priorities. So the work we do can review this and evolve it and bring it to life going forward. And hopefully, you know, clearly it's all very well if all the health and care providers understand that this work's going on, but if we can involve our community through yourselves and Healthwatch, then we should have much more impact. So at that point I was going to hand over to Julie, who's probably there. Are you there, Julie?
I am, Jane. Yes, thank you.
Welcome, Julie.
Have you got a purpose slide? I'll carry on with the slides, shall I?
Yeah, that'd be helpful to avoid disappointment. Thanks, Jane. In terms of the purpose, then I think it's really clear that we wanted to review how the whole system organises itself. So quite a few points that we've raised about it kind of not being that joined up and things falling down gaps between. It's important that we do that ideally for all patients' care, but particularly at end of life, and that we then aim to plan and deliver that end of life care. Our aims, obviously, as we said, are responsibly, compassionately, and importantly in line with the wishes of patients, carers and the families. We think it's part of the review to identify what works well, because there are things within our end of life care that are good, and we need to build on that. But that we do understand, what are the things that aren't going so well that can be improved, but being mindful of what the risks and constraints are, because again, one thing that I think that our response to the COVID is it's how you manage your constraints as much as anything is a real indication of how successful you'll be in delivering something. So it's us being really aware of any constraints and then working to mitigate those. We need to be able to plan then, once we've done that review, we've identified what's worked well and what doesn't. It's then how do we plan then to implement a change in in how we deliver the care, that makes sure that all of health and care staff are enabled, that we're supporting them to be able to deliver the high quality care that we know they want to give. It's what's getting in their way and how can we help them improve that. Then finally, the important bit is that if we've done the review, it's the so what bit. So then we've got to make sure we deliver those changes, and we do that in a supportive way, so that we do it very much in that sort of continuous learning. So we don't expect it to be right first time, but we expect us to learn as we go and to make those changes. And then the important bit is that when we've done that, and it's probably something that I think if we're honest, we've been less good at over the years, it's then demonstrating the benefit of the change that we've made, and how do we do that and link that to the patient-centred data, particularly around patient care and family experience. That's the key to this. If we get this right, then that end-of-life experience, we want it to be as good as it possibly can be. Next slide, please, Jane. Oh, we're trying. Oh, thank you. So we've suggested these as a set of principles to underline the review. And again, this is where we'd really like some feedback from Hosk. Are you comfortable with these principles? Have we missed anything? Because clearly we want to make sure that we've got public, patient, family and care involvement with this, because of the nature of the service. We have to ensure that that the health and care workers are equipped and enabled to do that, so that we very much get their input into this review and what in effect is getting in the way of delivering that good care. Making sure that we align our local work to the national guidance and best practice, which is very much what the end of life group has seen to do. Again, as a point I think you made earlier, Karen, making sure that we do get that integrated one approach across the patch, so we don't have a postcode lottery, as the expression goes, for our end of life care. We want to make sure that services work well, so it's absolutely not about blaming individuals. It's about what can we learn, because undoubtedly, even when we've done a review, there will be instances in the future where things don't go as well as we would want to. And I think what we've got to instill then is that we have a mechanism of taking that feedback and taking the learning from that and communicating that, so we're constantly striving to improve. As we said, we want to make sure that the whole the output of the review and the new and any changes we make to the end of life pathway are collaboratively designed, that they're delivered, across the public, colleagues on the overview and scrutiny committees, colleagues in Health Watch, all of the providers that touch end of life care. The integration of that provision is really key to this, and it's sometimes those provider silos that families and carers where they see the issues, and obviously the CCGs then being responsible for overseeing the delivery of those changes and monitoring that it's delivering the standard of care that we would want. And finally, again, I think Jane touched on this earlier, that we have got the full support of the STP Chief Exec, so this review would be accountable to them and to our emerging shadow ICS board. So with that, I'll I guess it's over to myself and Jane for the questions at the end, and to try and prompt that discussion and to ask for your feedback.
I suppose going back to your previous slide, you talked about that smooth working through the system within Telford, Wrekin and Shropshire. What Jill, George and I had in common with our experiences was that our partners, our husbands, came from outside of the system, moved into Shropshire. So the difficulty for me was actually getting him back into Shropshire. I know you can't talk about individual cases, but I suppose that's an area that I would hope you'd be able to pick up on, so that when patients who are in receipt of palliative care are, I say, if you like, using my husband as an example, he was at the University Hospital in Stoke, in Newcastle, and trying to get him from there back to Shropshire was a real pain. Trying to get him home to where he wanted to be because he knew that he was dying. That bit was really, really difficult, painful, and very, very stressful. And so it is that movement within the system from outside that I hope you're going to be able to pick up as well.
Absolutely, that cross border is key, because again, it's like people's lives don't fall into neat little boxes as we were, as the system is structured and wished it was. It's kind of messy, and it's not as simple as we would want it to be. So certainly I think those key out of area providers, particularly on the periphery of the county, we do need to make sure we link into that, and that ability to sort of repatriate our patients back to home. And again, if we link that into our plan, that we know that's what the patient wants, then we in effect have got that forewarning, haven't we? We've got to be able to make sure we can facilitate that repatriation as quickly as possible, and minimise the the amount of disruption and angst that's caused. And I think you're right. I know of cases in the south where that's not gone as well as we would want it to.
So are you saying one of the things that you're looking to do is to actually have a plan, an agreed plan with the patient, so that everybody is aware of what the patient wants, and that is almost like a passport they can take with them?
Absolutely.
That's what you're looking to do.
Yeah, and then that is what an advanced care plan is. So done well, a patient should have the discussions, have the opportunity for however many discussions is needed before they're repatriated, and a really clear plan that's documented and comes with them. And it's where there isn't that plan that things tend to fall apart.
So Lynn Crawley from Healthwatch Shropshire has just asked the question: are staff trained to have these difficult conversations, and when should they take place on the patient journey?
So yes, there is training, but what I would say is it's not reaching all the parts yet. So you're not going to find every member of staff has been trained yet or is feeling confident. What we've done is there's a small team of people for example, for the Telford and Wrekin care homes, we have a care home support team. And also there's a couple of doctors that have been coming out of SATH and visiting some of the care homes to enable this. So we've got examples where we do have extra support. But Derek Willis from the hospice this morning told me that we've just got some funding from HEE to do more training and development, because I think they recognise that we're on the right track, and therefore they're willing to support us in rolling that out. So yes, it is available, but probably not for all. And the answer to when is the right time, this isn't about a last minute planning of palliative care in the last few days. This is about how, when unfortunately is closing in and there are problems that are not going to be curative, that we have a discussion about how we want to live our lives and how we don't want to live our lives, and what will happen. I mean, that's why it's anticipatory care in the event. So really, before transfer, patients should also have, for example, all the medications written up that they might need, and they may well not need, but it's not difficult to do that as long as you've had the conversations beforehand.
Yeah, absolutely. Lynn, did you want to come back in on that point?
Yes, I've just added in the chat bar that one of the messages from our report was, because obviously when you talk to people about end of life, it touches on a range of services, doesn't it? And the people who'd had the most difficult journeys were the ones who, right up until the last minute, it seemed, it still hadn't been acknowledged that they were end of life.
And you're absolutely
everything
right,
was a struggle, everything was a fight.
And that is exactly where the training is so important. The other thing is we try and avoid using the term difficult conversation, because that puts you off before you started. You're a fairly junior member of staff. So we call it important conversations, because that's what they are. They are difficult. You can't deny that. But with support and training, and there's some, we've got a lot of expertise in the patch. It's how we can't have the people with the greatest experience doing it all the time. So how do we, end of life care is a generalist function. It should be for everybody that's involved in health and care, and how we enable that.
Couldn't it be argued as well, Jane, that the discussion needs to start when you're healthy?
Yes.
Because then it's not
Absolutely.
a difficult conversation
Well,
at all then, is it really?
I mean,
the
way Karen Stringer is, some of you might have come across Dr. Karen Stringer. She works up at Whitchurch Community Hospital at the moment. But she would argue that we should all be doing ours first. So we should all have a respect form. And why not? I mean, it's literally saying, how would I want to be treated if things turn difficult, and nothing's going to happen if they don't. So that might be one of the things we need to do, that every member of staff has the conversation, or has somebody have a conversation with them, and then maybe it becomes less difficult.
Yeah.
Good point. I've got a couple of people lining up to speak. I've got Derek first, and then Madge, and then Janet.
Thanks for that, Chair. Just a couple of things, to be honest. If I'd gone back 6 years, we're probably having exactly the same conversation with exactly the same plans that we had then. And that is sort of this talking out and having a patient plan right to the end, going across the borders with all the wishes, with all the families involved and everything else. And it has never taken off. And I don't know why it hasn't taken off. But this came before, I think it was either HOSC or it was certainly Telford Wrekin Scrutiny, many, as I say, 5 to 6 years ago. It's not about talking anymore. It's actually about doing. I mean, we're very unfortunate for Karen and unfortunate for Gil, but you've had two very senior people who have had extremely bad experiences with end of life, and that can't allow to continue. How many people have had exactly the same experience but are silent, who haven't been able to have this voice, who haven't been able to communicate? And I think there's a number of things wrong in the system. And the first one is that we have a complaints procedure. It shouldn't be a complaints procedure. It should be actually about how people communicate with you to tell you, look, this is what's happened. This is what's not happening. This is what we really need. If you're going to get it, don't get it from people like HOSC and all the rest. We can only ask the people, and we don't know the people who we have to ask, because only people with experience of this can tell us what's right and what's wrong with it. We need to actually make sure that when we go through these procedures, when people are involved in it, that there's a survey, there's a form, or there's ability to help the next people going along the way. It brings us on to the complaints, and it really isn't for you. This is probably for David Evans. Is David still on?
Yes, he's there.
Okay, but it's really for David Evans, and it is about this complaints procedure. What we found difficult in this one is actually when we asked for what complaints had been happening regarding this, we got, to say the least, a very scarce report, and it wasn't something we could actually bring back to it wasn't something could come back to the committee and everyone. It didn't tell us anything. It wasn't of any use to us. All we knew is with numbers. We didn't know what the problems were, how it happened. We really need a complaint system, and it doesn't only involve end of life. It actually involves all the complaints, and not to go to different providers, not to go to different places so you can search around. If we're going to make a difference, we actually need to make sure that it comes to one central point. And I ask all the health providers to actually think about how do you, if you've got officers involved and people involved in running a complaint system, or it shouldn't be a complaint system, but it's about a listening system, then it should be in actual fact across all of the health services. We should have one area where we can go to and say, look, what is a common problem here? What are we picking up on? Which hospital is bad? We don't want to read it in a grammatic form or saying 17 complaints. We want to know what's happening, where it's happening, and what the complaints are. And that can only be working. We are in a different world. We've talked about working across all of the health economies. This is another way of doing it. And I believe in the long run, it could save money, because you don't have to have 5, 6 different providers having their own system. Let's have one system where everybody can feed into it. And it can work. Thank you.
So, David or Julie, did you want to make comment on that?
I'll comment if that's okay, Karen.
Okay.
That's a very helpful suggestion, Derek. I mean, as you know, currently complaints complaints can be made to individual trusts or can be made to the CCG, or indeed can be made in other ways. And I think it is fair to say that there isn't necessarily a joined up approach to the way feedback, I'll call it feedback rather than complaints, is received or indeed processed within each of our organisations. And I'm more than happy to have a discussion with colleagues across the system to see if there is a better way for us to be able to do that.
Thank you, David. I've got Mad Shinton who wishes to speak, and Janet McLaughlin, and then Heather Kidd.
Thanks, Chairman. I'm thinking about the domiciliary workers again. You might think I'm obsessed with them, but yes, perhaps I am. They go into people's homes and they keep a lot of people away from the acute sector. Now, are they really trained in any way to have this sort of a discussion with their patient? And I doubt that very much indeed. So can their training, which seems to mostly consist of being able to lift patients with a hoist, etc., and how to work any gadgets they've got when it comes to shower, dress, etc., and that sort of thing. I feel sure that there might be some elderly people, particularly if they haven't got much in the way of near relatives, would be asking these sort of questions. And I think that these girls and boys, because that's what they mostly are, is girls and boys, should be made aware of how to go about it or where to tell the patient to contact. For instance, I'm very interested to hear about these respect forms. I'd only vaguely knew they exist. I have no idea where you get them from, or if you get the form and you filled it in, where you return it to. So can somebody enlighten me on that, please? Plus the fact, one other thing, and as someone who doesn't take medication, because the only thing that would interest me would be to be relieved of pain, that we should have medication forced on us is too strong a word, but medication which is an irrelevance when it comes to end of life. Thank you.
Shall I start with some of those and then Julie do feed in? I mean, I think your point around training care workers is really important, and what our community teams are trying to do, our trained staff, is to to enable the care workers as well, and we're working with SPIC around that. So the funding that I mentioned earlier that's coming into the hospice, we will do that as a system and look at, say, how our community staff and any trainers we're getting with this extra funding can enable the carers, because I think you're absolutely right there, and it's something that is challenging, but we would be able to train however inexperienced these carer might be, because what they are is really they're probably more experienced at the individuals they're working with, aren't they, than many people. So I think that's a good point. Respect, you can just download the form online. So I mean, they are available from health practitioners and care practitioners, but you can just Google Respect and you download your own and print it out, and you can look at it yourself, or you can go and choose who you have a conversation with, and then it does get signed off in the end by a senior clinician. But the forms are available, freely available. There's a lot of information on the hospice website that's worth taking a look at. And then the medication, so when I talked about anticipatory medication, that's absolutely not about forcing anyone to have any medications. That's really about that if you're deteriorating and you might need medications, for example, for pain, or if you're agitated, there are various, I mean, many of us have been involved with somebody who has had end of life, and there's various symptoms, nausea, feeling sick, and the problem is if you have them written up, then the clinician that's with you can make the decision with you as to whether you need them or not. So it's not about requiring, it's the opposite of a medication in a ward where they come round and say, right, it's 10 o'clock, you've got to have this. It's prescribed in anticipation, so that you're not, if you do need it, you're not having to wait for a doctor to come out and do a prescription. Does that make sense? Because I wouldn't want to in any way say we're trying to drug people through their care.
And if I can come into that one, Jen, I think that actually that anticipatory, those what they call end of life meds are really important, and they're actually really important for supporting particularly patients who's who are in care homes, for example, to enable it supports the care home to manage that patient, because that is that patient's home. That is where they may want to end their life. So it's really important that they're available to support that. So it's in that context that we would use that. And like I've got some personal experience with that recently with my dad, and that absolutely was the best possible way it could have been for him in a care home. And without those anticipatory meds, it would have been a very, very different experience. So I can assure you it's not forced on anyone, and it does enable as good an end of life as possible.
I can echo that as well. I mean, I was given a bag with end-of-life meds in it and just told, put it away in the cupboard, as and when you've any issues or problems, your clinician will ask, to see your end-of-life bag, and they will take the appropriate action without, as you say, having to look for prescriptions, especially when these things, issues often arise in the early hours, of the morning or late at night. So I did find that incredibly reassuring, just to have that pack away in the cupboard, knowing it was there as and when it was needed. I've got quite a number of people wanting to speak, as I say. Can I just ask a question? I've asked people to use the chat room because I've got a hand up, but I've got no idea who it is. So if you could identify yourself. Oh, is that you, Heather? I've got you down to speak anyway. So I've got Janet, then Heather, then Lynn Crawley. Oh, and then Dag. So Janet.
Hi, thanks, Karen. Mine is recently, personally, I've had where someone was on end of life and the community team wasn't there and couldn't support her at that time, so she spent extra time in hospital because it wasn't available, and it was over a weekend that no help could be given at that time, so spent extra time in hospital.
Julie, do you want to explain about Discharge to Assess? And then
So again, a lot of what the work that we're trying to do now is to make sure that, because obviously, again, a patient, you can't really fully assess a patient's needs and what they need when they're in an acute hospital. It's quite an artificial environment. So again, now what we're increasingly doing, and again, I think probably one of the positives that have come out of the recent pandemic is we've locally taken our discharge to assess to a whole new level, which means that we have got provision for patients to be assessed outside of an acute hospital to make sure that we've got the best possible view of what their needs are, that we can obviously try and maximise where we are absolutely committed to home first where that's possible, but where that isn't, how do we maximise the any rehab potential for individuals and get them to the best possible place. But obviously where it's end of life, it's then making sure, again, if we've got that advanced care plan, that helps obviously with the discharge planning. But if for example, we've got individuals that don't have that, that's an opportunity where we can put that in place, and again try and ensure that we assess those needs, we get the patients that get all those needs met in the best possible environment and not in an acute hospital. So we are now, I would say, our ability to discharge to assess and are getting patients from acute now, we are doing it within 24 hours.
Thank you.
That's reassuring.
So I think the difference there is that before COVID, we were wanting to make sure everything was in place for the return home. Now, I'm not going to say we send people home without everything in place, but we put in the immediate provision that's needed, the immediate care and medical care, and then you can at home get the team to sort of wrap what's needed in the longer term. So that hopefully would avoid, Janet, the issues that you just gave example of.
Okay, Heather.
Right, thank you. I've got 2 or 3 things to say. really interested in this, and lots of this is reassuring, and it's great that you're willing to learn, because I think one of the things that has come across to lots of people is that the NHS has not been very good at learning or listening. So this is really good stuff. Have you looked at what they did at Bishop's Castle Hospital when it was closed, and they actually had to get whole teams together? And the end of life care that people got was much better because of that working that you've been talking about, integrating people, the carers, the physiotherapists, everybody. And I just thought it was useful because we looked at that as a scrutiny in Shropshire, I think. It was under our Shropshire scrutiny. So it was useful stuff. My next point is around the complaints, which I support Derek completely on that, because you can go to the CCG, you can go to the hospital, you could go through a GP complaints procedure, you can go through Health Watch Shropshire. There are so many and people don't know where to start. And actually it shouldn't be called complaints, as you've already said. It really, whenever I've had to do this, I've wanted not to make a complaint, I just wanted to change things.
Yeah,
I wanted to make it better for someone else. And I've had 2 occurrences with daughters, not at end of life, but it's the same sort of thing, although I did have a terrible experience with my mother at end of life, but in Pembrokeshire, not here, where actually the only really big way I could make anyone hear was to complain. And I didn't want to do that. I just wanted to make sure nobody else faced that. And what people, and certainly what I wanted out of it, was to know that the system had changed so it couldn't happen again. And I'm not sure that the NHS, wherever you're complaining, is very good at letting you know what they've changed.
Yeah. And I think that's why we did raise the point at the end there, Heather, that in terms of it's about measuring that change, but based on the experience. And what I would say, I think I really welcome the feedback about that. So, as you say, to try and make it more of a listening, trying to get that feedback approach rather than it being seen in that complaint. Because you're absolutely right. All that anyone's interest is, they don't want anyone else to have the same experience they've had. The challenge we often get, and it is one we need to think through quite carefully, is clearly at the end of somebody's life, it's a very difficult time. And immediately it's kind of, we all get in the phase where we're in a restaurant, we're sick of having surveys, aren't we? We get asked, have you had an experience, and you just delete because you're sick of them. Whereas actually that feedback is really helpful, because we don't know what we don't know. And if people don't tell us, then we don't know what's wrong and we can't do something to put it right. But it's a very challenging area, and I think that's why the involvement with patients and public and the engagement, it's as much about how do we get that insight, when is a good time, how can we get that information, because immediately after somebody's died is not the right time. And then sometimes people think they've left it too long and then don't give the feedback. So there's a real balance there. So I think anything that we can get, and if our colleagues in Health Watch can help us, I think that's something there that's really important. We've got to understand how best to facilitate that conversation and to gain that learning when patients and their families are willing and in a position to do so.
And just to come back on the experience I had with my mum was in hospital. She'd had cancer 5 years before, had a lot of pain, hadn't been put in hospital. They suddenly found after 3 days that actually she got bone cancer and all sorts. There was no time for a conversation with anybody, and by the time I got to the hospital within 12 hours, they put her on a morphine pump, and she actually couldn't communicate or anything else, and the nurse came in and said, "Oh, this is on too high," and she died an hour later. It shouldn't have happened, but my brother wouldn't go through all the trauma of that. I know it shouldn't have happened, and I wouldn't have wanted that to happen to anyone else. I couldn't have saved my mother from that, but I would not want anyone else to face that.
So I do wonder, I think it's really helpful that you're sharing this and sort of challenging us, because in some ways, one of the things we could do through this review, I know we're talking more broadly than just end of life with respect to complaints, but if we could somehow together and involving Health Watch look at how we could set up a system, feedback, end-of-life feedback system for the system. You know, that could both, maybe that's core to how we do this review, and then that actually could forge a different way forward as well, and we could spread that to other areas.
Brilliant, thank you.
I think, Jane, if I can just come in, the people that I had a huge amount of contact with once I managed to get my husband home was the hospice at home service. And once you've got that kind of relationship with nurses who, you know, you can have very intimate conversations with them, personal conversations, that would be a conversation that maybe, I don't know what their workload is like, but a follow-up after the patient has died, almost like a follow-up conversation with that nurse. I know that at the time I didn't want to put in a complaint about anything. I didn't have the emotional wherewithal to do that, but I would have probably have had a conversation with the nurse who had been visiting, you know, for the last 3 weeks of my husband's life. So I don't know if that could be an option.
Really good idea. Really good idea.
I've got Lynn Crawley who wants to speak, and also Dag Saunders, and then Derek.
Thank you, Karen, for that opportunity. A couple of things really, and it's partly picking up on what Derek had mentioned before about feedback. Just to give you a bit of a context, I set up the Independent Health Complaints Advocacy Service that is run by Healthwatch Shropshire, and we're in our 5th year of doing that. And I think it's important to just think about language for a moment, because the NHS complaints process applies to formal complaints, and then you've got the feedback and concerns which fall outside the NHS complaints process. The function of both Healthwatch and Healthwatch nationally is to be the central point for people to give feedback about services, which is what Derek was asking for, and that's what Healthwatch was set up to be. So people can leave their feedback with us about any service and any journey across the services and any pathway that they've been part of. So I really would like the committee to just think about that as being our primary function, which is why we have information sharing agreements with all the providers, which is why we share our comments with providers on a regular basis. Now, the power of that feedback relies on more people sharing their comments with us, because sometimes we don't get an enormous amount of comments as a Healthwatch. So it's about the whole system promoting us in that role, so that then we can start joining up the dots and identifying where the issues are. But I just want to reassure you that we do share our comments with the providers in order for them to make a difference. When people, we appreciate that people don't always want to go through the NHS complaints process, but if you make a formal complaint to a provider, that provider then should take ownership of that, and they should liaise with all the other providers involved in that patient's experience to come back with one single response to the complaint. So patients should never be told, oh, well, that part of your complaint isn't anything to do with us. It relates to the ambulance service, or it relates to the council. So the first organisation who's contacted should take the lead on liaising with everyone else to come back with one response. And so we do sometimes have to remind providers that that is their responsibility. The disadvantage is it can slow down the process, because it means that they're then reliant on all those other providers to share their response to the complaint. So I just wanted to really reiterate those two facts, really, that the distinction. And sometimes we explain to people that making a formal NHS complaint is the only way that you can be guaranteed a response to your complaint, whereas if you simply give feedback, unless you specifically ask for it, you're not going to get a response. It will be just accepted as a piece of feedback and logged with all the other feedback. And that's the same as if you were to raise a concern. So our role within Healthwatch Shropshire is to constantly remind people of the distinction, because people think they've made a complaint and never get a response, and that's because they didn't explain that it was a formal complaint and they didn't ask for a response to it. That's why we exist as the Independent Health Complaints Advocacy Service, to help people understand the complaints process and what they can realistically expect as an outcome of that. So, for example, some people, you know, what they really want is a staff member to be dismissed. So right at the beginning, we can talk about what is a realistic outcome of their complaint, rather than them go through a potentially a year-long process, if not longer, and then never be satisfied. So we, right from the beginning, we talk to them about what it is they want and what is most likely to happen as a result of it. And we cover the whole of the local authority region of Shropshire, but also anyone using a Shropshire service. So that includes Telford and Wrekin residents using RGH, MPF2, the Community Health Trust, RSH. We have quite a wide remit in Shropshire.
Thank you for that, Lynn. That was really helpful and useful, you know, for understanding and learning the difference between a complaint and a concern. I have personal experience of going through the formal process of a complaint. This was with a hospital in Manchester with my mother, who had a do not resuscitate order placed against her without her knowledge. And that took the best part of 9-10 months, I think it was, to actually work our way through. And again, rather like Heather was saying, I didn't want somebody's head on a pole. I just wanted to know. I mean, my mother's shock when she eventually recovered to find this do not resuscitate notice amongst her paperwork was it was a great shock. I just wanted to know that this wasn't going to happen again. But I had to go through, and it was, you know, quite an emotionally draining process to go through. It's very hard, formalized, and I understand why it has to be. But I think I think that is why we shouldn't try to invent the wheel when we've already got the wheel. You know, i.e. with Healthwatch. I think that's basically what you're saying, isn't it?
Yeah, definitely. I mean, that is what we were set up for. That's our statutory function, is to gather that feedback, share it back into the system, which is why we have the regular meetings with the CCG, the trusts, in order to make sure that they hear the patient voice.
Okay, thanks for that, Lynn. I've got Dag and then Derek.
First of all, obviously fully support everything Lynn has said. Fine, Lynn. Just asking if there is input from different cultures and different faiths in terms to end of life and end of life care.
Good point.
I suppose this comes back to we haven't got a worked up plan as to how we're going to do that, but I think that's a really important point. And the way that we engage both staff and the community we're serving needs to be in an inclusive way, taking into account diversity. So so I can't say how we're going to do that, but you're absolutely right that that's essential.
Yeah, definitely. Okay, Derek.
Yeah, thank you very much for that, Lynn. But the reality is I'm not trying to invent the wheel. What I'm trying to invent is a wheel that actually rolls. Now, on your own admission that basically that, you know, you get relatively few complaints, comments, etc. And you're always struggling for that. So if we're going to have a wheel, let's make sure that it is available and people know how to access that wheel, how to get into that complaint, that ability. Now, it would make a damn sight more sense for all the complaints to come to Healthwatch, the joint Healthwatch, and you be able to guide the people down the right channels. Because you're right, going through this appeals procedure, this complaints procedure, is an absolute nightmare for most families. And the last thing you need, especially at the end of life, is to go down that after your loved ones, because it gets more bitter and more angry, and the anger comes out in different ways. Now, it would, so we have to make sure that Healthwatch, and it is a joint Healthwatch, I would have hoped, that you actually share these complaints, you share the experiences, you share what the concerns are, because then we have the common factor across all of Shropshire. So it's actually, how do we actually make that work, Lynn? How do we actually make the thing? But before you answer that one, what I'd like to say is, you know, one of the biggest conversations here is about staff's attitude, about making sure that all this.
You've got on mute, Derek.
Yeah, I just muted myself. Yeah, I must have thought, Christ, I'm talking too much here. Anyway, but basically, what this, to me, we actually have to, we have to change it. We know there's a real problem with staff attitude. I mean, it's come, you know, it's come through time and time again. I find that the community nursing is far more friendly, people friendly than in the main hospitals. And we have to change that. I mean, we've had the chief executive and everyone else saying, look, there is almost a culture within the hospital system, and it's not a good culture. And they're trying like desperately change that. But for this to work, we've actually got to make sure that everybody's got that culture. Everybody's going to make sure that people, you know, at the end of the day have got the concerns. They've got the ability to express themselves. They've got to make sure that they're doing the right thing for the right people and that their families are involved and a part of that decision making as against being made against their life. And as I say, what happened with Karen's mum. So it's just a case of how do we change that culture? If the chief executive of the hospital is struggling, how do we actually do it at this level?
I was just going to respond to the first part of it, Derek, which was about raising the awareness of the role of Health Watch, and that's why it's important for Health Watch, and it's my mission to be in as many meetings as possible to remind people of the role of Health Watch, and it is one of the primary roles of our engagement officer within going out into the community to make sure people understand that we're there. But it's also important that the providers support both Health Watch in raising the public's awareness. So, you know, all the trusts have our details on their website, which we're grateful for, but it will be a never-ending job to make sure that people know that we exist, because like so many things, people only need to know about us at those moments when they've got something to say. So it's a constant job.
But Lynn, if you're having to remind the providers, and there's far fewer providers than there is actual people, then you know you're really trying to push a thing uphill. You've got you keep on, you sit here and I keep on having to remind them. Why should you have to keep on reminding? It's a part of the way the procedure should happen, and we have got to try and find ways of actually promoting it. And it's not just the hospitals, it's not just the thing, but every one of us have to help you actually become that hub, that area where people become, because I know Health Watch has been in existence for a fair while now, and people should know about it, and it just doesn't seem to happen, does it?
No, but I've sort of accepted that it's my mission to raise awareness, and I think that's, you know, both Health Watch, we understand that we're constantly going to have to not only explain what we do, but also break a few myths about what we do as well. So, but I think that's just the way it is because of the role that we have within the system.
Can I just comment that it goes back to what one of the things Derek said a while ago, actually, around, well, why is it going to be any difference this time? Because you've seen this sort of plan and had this sort of discussion before. I think there is something slightly different happening across the system now, across Shropshire, Telford and Wrekin. For starters, we are talking about the whole of Shropshire, Telford and Wrekin, for example, at this meeting now. You know, there's been, and just from my learning around Health Watch, I've had several conversations with Lynn, and she is involved in lots of discussions I'm in, and so I'm learning. And I don't know, Julie and Dave will probably comment, but I do think that providers, commissioners, third sector organisations, Health Watch, we are having more conversations together now with a collective ambition. Now, I'm not saying it's all going to be straightforward, but I think that's why it could be different now.
Yeah, I'd agree, Jane.
Yes, I agree with that. I think I'm just sort of looking at this last slide, and I think we've touched on the scope of system and end of life review. We've touched upon that, and I think we've contributed a few suggestions. The leadership and governance, I don't think we've quite covered that yet. Apart from it comes under the STP, what is the governance of it going to be, and where is that going to sit with the STP as well?
Dave, do you want to take that one?
Yeah, Governance within the system, when we're starting talking about the system's an interesting concept in a sense, Karen. It will go through the STP, but clearly, if there are financial implications or changes to the way services are being delivered that impact on providers, it will need to go through the various statutory organisations. There's no getting away from that. However, of course, all of the chief execs of the various organisations sit on the chief execs group and indeed the ICS shadow board, so that at least should make that passage smoother.
Yeah, that's a clear line for communication, isn't there, as and when any issues arise. Oh, that's reassuring. And then
I think one of our questions was actually with respect to leadership, how we could work with yourselves. So clearly we've got Lynn and Paul with respect to Health Watch, but with joint HOSCs, our question was around yourselves as well.
I think there is an appetite here to work with you. I think it's just defining how that will look, you know, what that involvement will be like. I think you've also, I think in some of the conversations I've seen, you've also said that that would also include the public, members of the public, patient, family and carer, as it says here, engagement. So that's encouraging. I think taking into the point about Dag's point about the minority patients, the BAME. I don't really like that term. It just sounds, I don't know. But anyway, those whose first language is not English, I think that really needs to be picked up there. And then the next bullet point is the next steps, including timeframes. I wonder, can you elaborate on that a little bit more?
Julie, you're sitting behind me in the pictures. It's quite funny on this screen, or I can just see the top of your head, so there's no body language going on here. But do you want to take that one?
Yeah, so obviously I think in terms of next steps, we obviously, before we drafted a formal terms of reference for the review, we wanted this conversation, and I think this has been really helpful. So thank you to everyone that's contributed. I think our key next steps are to get a draft terms of reference agreed. Again, I don't really want to, we want to be quite pacey about this and get on with it, but I think I certainly don't know about you, Joe. I think we should, it doesn't stop us making a start on the review, but I think it'd be helpful if we could bring that back to HOSC and get you to, you know, formally support those terms of reference and make sure that everybody's bought into what we're trying to achieve. In terms of timeframes, Jane and I have had a conversation that I think if we are going to do this properly, and I mean to do, you know, we could do it quickly, but it's not going to have the engagement. It's not going to, as we've talked about, how difficult it is to canvass some of that feedback and that interaction with the public around such a sensitive area. I would rather us do it properly and take longer to make sure we've done that proper engagement and co-production. So my honest view is that we're, you know, to get some final sort of recommendations, I think we're probably talking 6 months, but I think there's no reason why we can't bring an update part way through, particularly on that patient and public engagement and that co-production, and have that sort of dip check with HOSC at the sort of 3-month point. But what I'd obviously need to put a caveat around that, and that is obviously subject to how the winter goes and how COVID behaves itself during the winter. Obviously, if we do find ourselves in another difficult position and we had to, you know, pull back on what we were doing, that would have an impact on that. But focus on the positives. I think we could do a really good comprehensive piece of work within 6 months, but keep HOSC informed, have that midpoint review with you, and also get you to formally sign off the terms of reference. Is that? I think that's what we discussed, Jane.
I think time is of the essence, but I think it's about getting it right, isn't it, as well? Because, you know, whilst we're working on plans and strategies and all the rest of it, people are still dying.
Absolutely.
You know, they're still going through end of life.
And if we find anything, I would want to reassure, as we've done with all reviews, if we find something in the short term that's a problem, we will make sure we put it right. It's not that anything that we find is a problem, we're going to wait until the end. That's for more of the sort of strategic changes. If in the here and now we find particular issues, rest assured that I know both Jane and I would want those corrected straight away.
Yeah, and so when you're drawing up the terms of reference, who are you going to include in that sort of work team, if you like, of drawing up the terms of reference? Who will be doing that piece of work?
That in the first instance, we've identified a commissioning manager that's going to be the sort of the management support on this piece of work and to do that work, which is David Whiting, who's worked on end of life and is also part of the end of life group, the clinical group that Jane alluded to earlier. So he's going to be the person kind of holding the ring on that, but obviously with mine and Jane's support. I think we did touch on, but it would be helpful to know if we've got any queries in the meantime. Would it be you and Derek? Would you be the touch points for the joint HOSC in the meantime?
Yeah, definitely. Yeah. Derek, did you want to come in?
Yeah, basically, if it's going to come back to us, then, in order for us to have because it sounds really good that we can have a really big joined up thing, but basically what we can do as Scrutiny is actually, when you do present it, that we have representatives from all the different people involved to actually make sure that they are signed up to this. Because the thing about it is we can agree on a strategy, but it's how the providers in the other areas are actually going to support it and make sure they support it. But it's something perhaps that Karen and myself can talk about it at a later date when it comes closer. That's if Karen's going to be, depending on the length of time. Hopefully Karen will be there to help and support it, because it'd be a great benefit.
Yeah, and I'm confident we have got we will have the provider support, because we've got all of their chief executives underwriting this through, as Dave alluded to, through the ICS board. But I appreciate your support on that, Derek.
Yeah,
and I think
for me, it's
helpful.
Simple. Sorry.
No, I was just saying, I think that's very helpful to have a couple of you as sort of the first point of contact with Joint HOSC. And I think your point's really helpful around scrutiny, because we do want to co-produce this with you, but this can't just be a cosy conversation, can it? So I think that's helpful to think through. And the other thing is, what we're doing at the moment is trying to gradually evolve and transform services to meet the needs of our population, despite COVID and winter and the problems that are, for example, at SAS at the moment and all of that. So I would see this as a catalyst to improving things as we go along. I wouldn't see this as a paper-based review that then we think what we're going to do next year. I think by doing this review, we're going to precipitate the impact of the training we're doing, the discussions that are in the community around this. Hopefully more people. One of the things perhaps we could measure is, how many more people in the community have their respect forms adequately filled in with some support by the end. So this should be action learning, not just a paper-based report.
Yeah, absolutely. And the one thing, sorry, I forgot to mention it earlier on, was around equipment. And that is something I picked up again anecdotally, from people. It's actually getting the equipment out at the right time. That was my own experience as well. Getting the equipment out at the right time, but then also recovering it.
Yeah.
But that feels like a huge piece of work, looking at the equipment stores, doesn't it? And how they operate.
Well, again, I think that's outside the remit of this. What we need is, what will come out of this is what the ask is of the equipment stores, and one of the recommendations, we then take that forward in our sort of contractual terms with that service. So I think that's how I'd suggest we approach that, Karen.
Okay, no, that does make sense. But the reason I brought it up, it is one of the things that impacts on end of life care.
Yeah.
Okay, so the next step, including timeframes, is we're going to bring this back then. You say about 3 months, so where does that take us? Where are we now? We're August, September, October, November. Should we say December?
Yeah.
Okay. Right, well, Derek, have you still got your hand up that you want to say something, or is that from previous?
No, I'm just ignoring myself again.
You're just waving again.
Yeah.
Okay, well, can I say thank you very much, Jane, Julie and David. We've gone slightly over time, I know, but this has been a really important piece of work, and it will be good to see it through to its conclusion. hopefully next year.
And thank you. Thanks for your support.
Thank you.
Thanks.
Cheers.
Okay.
Bye.
Thank you very
much,
much, everybody.
Thank you.
Bye.